Good evening, everyone. My name's Dr. Nick Yim, GP in Harvey Bay.
My name's Mark McMurtrie. I'm a pharmacist. Welcome back to another episode of the Dispensary channel, where your weekly updates for health professional tips, product reviews, wine reviews, and we're keeping your finger on the pulse with the latest in outages and updates.
Yeah. So I guess tonight's topic is we're going to have a bit of a case study. We're going to talk about shingles because that's a pretty common presentation in our community. But what I saw last week was a bit of an episode by yourself on Epipen. And for those of you who haven't seen it, have a look at the link below. Because what I was quite surprised about was the size of that needle. That's
just how deep it goes.
That's impressive.
That's a whopper, isn't it?
Yeah. But that was a good little video, Mark. I think the consumers would actually enjoy watching that one.
Yeah, good to see how it goes and how to use it and some little tips.
Yeah. So moving on to tonight, let's talk about shingles.
Shingles it is. No, it was interesting because I'm actually seeing a few more cases popping up. I'm not sure if it's to do with the heat or whatnot, but I'm always interested to see how each doctor treats shingles differently. Over the years, I've seen how it presents, and hopefully I can teach a few pharmacists some of the little things to watch out for, because more often than not, I've found that they'll present to you in the pharmacy and get your opinion on something if they don't actually know what they're looking for. If they don't know they've got shingles, they'll just come to the pharmacy for a cream or something, and it might be a missed opportunity to jump straight onto that. Yeah,
absolutely. I think as a GP, the shingles diagnosis, it's tricky. It's not straightforward, and I can't imagine the difficulties that sometimes pharmacists can see, especially in the over-the-counter interaction.
Yeah.
Similarly, like as a GP, unfortunately, I have seen a few instances where steroid cream has been prescribed for a rash, where they thought, rightfully at the time, they thought maybe it was a bit of dermatitis, but then actually later down the track, when you do take a little bit extra history, you realise, it probably was herpes zoster.
Yeah, it takes a bit of experience. I mean, there's always those few red flags. Once you get to know them and you see them often enough, you go, look, let's just jump straight onto this. I've had a few patients where they come in and say, look, I'm getting pain across the side of my torso, immediately alarm bells, or any sort of unilateral pain, especially near the eye. I've found that one. So I don't muck around with that anymore. I used to give them a cream or say let's try something, but I think now when it comes to shingles, we've really got to jump on it early as possible. And I'll say, I've got no hesitation saying, look, let's try and see a doctor today.
Yep, definitely. And I think the key thing is for pharmacists out there who are listening, if it's a unilateral rash, only on one side, if you're seeing blisters or vesicles, and if it just doesn't seem quite right, it doesn't match the clinical picture of a dermatitis or eczema type pain, I think pick up that phone and call the GP to see whether you can get a review straight away.
Yeah, that's a good idea.
It is fortunate that Mark and I, we work pretty much next door to each other, and if Mark spots something that he's not sure about, he often knocks my door or even gives me a phone call, and we can see that patient straight away, because as Mark was mentioning, early treatment with antivirals is key for this patient. The other thing that I've noticed in my clinical practice is shingles is actually occurring at a much younger age. It's something where I have been seeing even 20-year-olds, 30-year-olds. It's not just a illness of the elderly.
Yeah. Okay. There you go. So I mean that's interesting that Nick says that. It's first of all, I think it's a great idea that we get comfortable picking up the phone and calling through to the GP and seeing if they're happy to see the patient and their thoughts on getting in, because it's almost like the other viral infections with cold sores, etc. You've got to really jump on it within the first day, maybe 3 days at the latest, with that window of opportunity to get antiviral medicines in. Is that right? Yeah. So that's why I like to consider this one of those red flag moments, even if you train your back of counter staff to pick up those little referral points to the pharmacist, and then we can refer off to a doctor if we find that it's necessary.
Yeah, definitely. So I guess like for GPs and also junior doctors out there, What do we use to treat shingles? There's a few things that we can utilize, especially if we pick it up early enough, and that's something such as antivirals, something like valacyclovir. That's something where I often go to because it's easy to dose. It is PBS and it's off patent now, so it is relatively cheap. I think the key thing is being aware what the PBS requirements is, because for shingles, it's only within the first 72 hours of when the blisters arise. But I guess anecdotally, if someone has a rash that was there for maybe 4 days or 5 days, I would still probably give them a prescription. But I'd warn them that it's not PBS, it's private, and I think the price of a PBS valacyclovir script, what is it, Mark?
Chips.
What is it these days?
$20, $25.
Yeah, so it's very, very cheap. Okay. So that's the first element, is reducing, I guess, the spread. But I guess the other big problem with shingles is pain. It's something that can be acute, and it also can be chronic.
Very painful.
Yeah.
And I've heard it lasting for close to a year in some cases.
Sometimes it could be even forever.
Oh, no kidding. Yeah, there you go. So what's your go-to? Because I've seen a lot of doctors throw Lyrica at it, you throw high codeine painkillers at it. What's your go-to now?
It's tricky, Mark. It's something where it's what I teach my medical students and registrars, where ideally we want to have the stepwise approach. Okay, so good old-fashioned paracetamol.
Yep.
Okay, I think that's something that should be first line.
Yeah, absolutely.
Okay, but it is a neuropathic pain. Okay, it is painful. Okay.
Yep.
And it's trying to find an agent that you're comfortable with, and also in conjunction with the patient's other comorbidities. So if someone is already on maybe benzodiazepines, opiates, maybe antidepressants, and they're risk of serotonin syndrome, you might not choose something like amitriptyline. Amitriptyline is actually a very, very good drug. I find 10 milligrams. It's cheap.
It's getting popular now these days, amitriptyline. I'm seeing that more often.
Yeah. So that's quite effective. You mentioned pregabalin. Pregabalin still has its role. But I guess this is purely anecdotal in clinical practice. I have been finding maybe even gabapentin quite effective. But there's also topical treatments as well. And I think we've tried some topical treatments with some of our mutual patients as well.
Well, that's it. I mean, I'm seeing more lignocaine coming through, and that's a toughie, because I mean, some of the stronger stuff is very expensive, and some of these patients are very cost sensitive.
Yeah.
I've actually found, interestingly enough, is there's some great new products coming out used topically as a spray for sunburns, which are now getting higher in lignocaine. So we're still, covering that immediate topical relief with the spray and the lignocaine. I mean, it's short acting, but a few of my patients have come back and said that was a lifesaver.
Yeah.
Their pain was really that bad.
It might be a bit more cost effective.
Oh, sure is. I mean, that spray bottle lasts them, 3 or 4 days, and it's about $12-14.
Yeah, because there is a lignocaine patch available now, even over the counter and on scripts. But I guess pricing can be a bit of a restraint.
Pricing and then location, like you just put a patch on, whereas you might need more of a broader approach.
Yeah, definitely.
Yeah.
And I think one thing that we often forget about is the capsaicin cream.
Yeah, I actually keep that on shelf, and I recommend it. I do give them the warning. It works wonders, but they've just got to be aware of how to use it and what to watch out for.
Yep, definitely. So I think those are the key things about shingles.
Yep.
I think it's early detection.
Yes, absolutely.
And also managing the post-hepatic neuralgia.
Yeah.
Okay. And it's warning that patient where it can actually last for essentially potentially years. But early treatment can prevent that from occurring.
That saves it a bit. What about prevention so we've got the Zostavax, the varicella zoster injection.
Yep.
I think that's a great idea that we use that. It's PBS listed for 70 to 79-year-olds.
Oh, not quite. It's actually on the immunisation schedule, Mark.
Yeah, right.
Yeah, so it's actually, they don't have to actually pay. So for our patients who are between the ages of 70 and 79, they actually get it for free.
Get it for free.
Yeah.
So go see your doctor. I think that's actually not a bad idea for pharmacists too, because we get to see our patients' date of birth as they come through on scripts. You can almost have a 70-year birthday card that says, "Happy birthday, go see your doctor." Huh?
Yeah, and that's valid. Like for me personally, often it's ideally I'd like to pick them up hopefully when they do turn 70. But what I often utilise is the over 75 health check when they come in for their over 75 driver's license. I often double check on their file whether they've had their shingles vaccine. And if they haven't, we give it to them. There are a few contraindications, and obviously that's something to be aware of, but majority of patients can have the shingles vaccine.
So I was actually interested to hear earlier that it's only 50% effective. Is that right?
Yeah, based on that product information, they do quote the overall effectiveness to prevent shingles. It's only at 50%.
Wow, okay. And is that just for the 70 to 79-year-olds?
It's actually the overall. So, interestingly enough, the efficacy at preventing shingles reduces as the patient gets older.
So, get the shot earlier?
Yeah, ideally, obviously appropriate counselling and speaking to your patient. If we can give the injection earlier, it's probably going to be more efficacious to prevent shingles.
So what's the earliest it's indicated for?
So Zostavax, the shingles vaccination, is indicated for people over the age of 50.
50-year-olds. Yeah. Okay.
So there are many people that might be keen to have that injection earlier. Okay. So people might have experience, or maybe their loved ones having post-herpetic neuralgia. But don't forget our DVA patients. So people who do carry the DVA gold card, they're actually eligible for many subsidised medications, okay? And also maybe your patients who might have extras covers with pharmaceuticals.
Yeah, that's a good point.
Okay, so it's something where, and also don't forget about your general patient who might be happy to pay.
It's about $200, $210, I think.
Yeah, for the immunisation, which is a one-off immunisation. So it's something to consider.
Absolutely. Anything else we can talk about with shingles?
No, I think the key messages are, I guess, for the GP, it's all about that communication with the patient and the pharmacist. Early detection is key, okay? So be highly suspicious of the unilateral vesicular rash that just doesn't sit quite right. I generally swab that area just for public health reasons as well. Okay. But that doesn't delay my treatment.
I think it's almost later down the track. It'd be interesting to see if this becomes a pharmacist prescribing a antiviral earlier on, because I think early detection and early treatment is the key with this. But again, it comes down to vigilance with access and how we can diagnose.
Yeah, I think that's going to be something that's going to be a little bit grey. It'll be an interesting area. Obviously, we do have the obviously the prescribing schedule already that the S3 medications that pharmacists do have.
Well, that's it. Well, I mean, at the moment, pharmacists just have to be aware of what the signs are, and don't be afraid to pick up that phone, call the GP, and see if they can get that early.
And probably don't recommend steroid cream for a vesicular rash.
Yeah, well, that's it. I mean, I rarely use it now, especially if they're seeing the doctor in the next day or so, because it just makes it look better. And then it's harder. I suppose it's harder for you.
Exactly. Like if the steroid cream's prescribed, often it takes away the redness, and you go, what is it? Not too sure what it is.
Yeah, that's
and
tough.
then we might sit tight a little bit longer as well.
Yeah, delaying that access. All right. Should we review a wine?
Why not? Just letting you know, we're in Harvey Bay at the moment, and it's sweltering.
It's scorching hot.
It's great being on the beach.
The humidity is killing it.
But we've thought that due to popular review, we've had a few recommendations that they loved the wine reviews on our first episode.
Yep.
So what I've done is, it's actually half the bottle. We've started drinking already because it's been pretty warm.
A little bit.
We've pulled out a Howard's Vineyard from Adelaide Hills, a 2018 Cabernet Franc Rosé. What do you reckon, Mark?
Mate, I'm already hooked on this. I think this has got to be the summer wine for this year, because it is just absolutely refreshing, and it's a bit moreish, isn't it?
Absolutely. So
it's so clear. It's such a clear wine.
It's very light.
It's got a nice dry finish to it too.
Yep.
So it just makes you want to keep drinking it. It's very dangerous.
Very easy to drink. Clean on the palate, refreshing.
I like the fruitiness of it. So the clean fruitiness is just absolutely hitting it for me.
Definitely.
In fact, I could probably mix that with a bit of Sprite or something. I like my sweetness. I mean, it's dry, but I like the sweetness, and that'd be my favourite for summer.
Yeah, absolutely. With maybe a cheese platter, bit of seafood,
Ooh,
can't
now
go
you're
wrong. Yeah. So, what's happening? What's in stock? What's out of stock? What's back in stock?
Slowly getting dribbles back of ranitidine.
Mm-hmm.
The usuals are still out, same as last week. Nothing else new is out.
Yeah. Is Epipen back in stock because there was a bit of shortage?
The Junior had a shortage for a bit. The Pharmacist can still phone up the number. I'll put the number below somewhere. And you can actually get your back order pushed through if you phone the number. It's good for GPs to know that we can get that immediate access if you need to.
Yeah. I think one recommendation, what I find, and I have a pretty good working relationship with all the pharmacists in my local area, is if there's something in stock, out of stock, such as the issue with the H2 antagonists at the moment, pick up the phone when your patient's there with the script and just ask the GPs, like, do you mind switching it to something else? It just saves the patient coming back to the GP, going back to the pharmacist, just one trip.
Cut out the middleman, just get it done.
With any stock shortages, or even if we prescribed the wrong strength, wrong quantity, just fix it up there and then. I know when I trained, we were almost trained in communication where you pick up the phone, speak to the GP. I think that's really crucial. Sure, there might be times when we might be in a procedure or doing a intimate examination, we can't pick up the phone. But I know that when I've spoken to my receptionist, there's a pharmacist on the line, put them straight through.
I'll tell all the pharmacists listening, I'll tell you my 3 favourite words. I say this every time I call the doctor, and I say, it's 4 words, sorry. Is it? I'm going to count it. 3 words if I'm really upset. No, 4 words is, I know you're busy.
Yeah.
Right? I always start my sentence with that. I pick up the phone, the doctor says, it's Dr. Nick here. I say, no, you're busy, Nick. I'll be quick. I've just got to chat to you about so-and-so. And then usually the rest of the conversation's free flowing, and they're appreciative of the phone call.
Yep.
But do your homework, know your stuff before you phone, and always have a recommendation. If you phone up just out of the blue and say I've got a problem without offering a solution, then it sort of staggers everything. But I think those 4 words are a lifesaver.
Absolutely. Pick up the phone. Can't go wrong. I know I pick up the phone and speak to Mark all the time, especially if I don't know what medication prescribe or what's in stock or what's out of stock.
Yep.
Yeah.
That's how it should be.
Yep. Anything else for tonight?
Nothing else I'm going to talk about tonight. We'll keep it short and sweet.
Right.
We'll have another episode for you next week, and we'll talk more about what's happening in the news, hey?
Sounds good.
Sounds good.
All right. Stay safe, everyone. We'll see you next week.
Until next week. See you later.